Buenos días a todos. Muchas gracias por haber venido esta mañana con el tráfico que todos hemos encontrado, gracias a las obras de la Costa Verde. Bueno, buenos días. Tenemos hoy día la segunda actividad de la Cátedra de Psicoanálisis Británico con Alessandra Lema, que es nuestra invitada de esta tercera edición de este importante evento, que tiene como objetivo traer cada 2 años al Perú a un o a una analista de la Sociedad Británica de Psicoanálisis a pasar unos días en nuestra comunidad psicoanalítica, integrando tanto a los programas de posgrado de la Universidad Católica, los programas de psicoanálisis y la Sociedad Peruana de Psicoanálisis como principales organizadores, y también a otros centros e instituciones para los cuales el psicoanálisis es un tema de interés. Yo les voy a presentar a nuestra invitada de hoy, a la cual muchos de ustedes ya conocen por los libros, por los artículos, a nuestros estudiantes porque justamente trabajamos con el modelo de terapia que ella nos viene a presentar ahora, y que es una adaptación de la técnica psicoanalítica que tiene la capacidad de llegar a poblaciones que normalmente no se pueden beneficiar con una terapia psicoanalítica de largo aliento. La doctora Lema, la profesora Lema, es psicóloga clínica, psicoanalista y miembro de la Sociedad Británica de Psicoanálisis. Ha trabajado en el sector de servicios de salud mental durante más de 30 años, especializándose en el tratamiento de adultos y adolescentes. Durante 16 años trabajó en la clínica Tavistock, donde fue jefa de psicología y profesora en colaboración con programas de la Universidad de Essex. Actualmente es codirectora del servicio de terapia y consulta para jóvenes en Queen Anne Street Practice, donde trabaja con adolescentes y adultos. Además de su entrenamiento en intervenciones psicoanalíticas a largo plazo y su trabajo como psicoanalista, también es entrenadora, supervisora y terapeuta con experiencia en una serie de intervenciones psicológicas breves basadas en evidencia, como la terapia interpersonal dinámica breve, de la cual es coautora junto con Mary Target y Peter Fonagy, y de lo cual nos va a hablar este día. Es consultora y psicóloga clínica en el Centro Nacional Anna Freud para Niños y Familias, profesora visitante de la Unidad de Psicoanálisis del University College London, profesora visitante del Instituto Winnicott de la Universidad Sapienza en Roma y el Centro Winnicott de Roma. Es editora de la serie de libros que todos ustedes conocen, The New Library of Psychoanalysis, y editora regional del International Journal of Psychoanalysis. Su experiencia clínica se concentra en el tratamiento de trastornos del estado de ánimo, depresión, ansiedad, alteraciones de la imagen corporal, en particular trastorno dismórfico corporal, trastornos de la alimentación, trauma y autolesiones, adicción a los medios digitales, problemas relacionados con la identidad de género, transgénero y el deseo sexual, entre otros. Da conferencias a nivel internacional sobre todos estos temas y ha publicado extensamente en estas áreas. Sus libros han sido traducidos al italiano, español, griego, taiwanés, alemán y polaco. Tenemos entonces el privilegio de tener a una clínica y académica de primer nivel entre nosotros, para de primera mano, de la mano de la autora, conocer un poco sobre la terapia dinámica interpersonal. La estructura de esta reunión va a tener 2 partes. Vamos a tener una primera parte hasta las 11:30, donde vamos a hacer un pequeño break, y luego a las 11:45 retomamos para finalizar el taller y dejaremos un espacio al final, obviamente, para las preguntas. Además de agradecer la presencia de todos ustedes, yo quiero hacer un agradecimiento especial a nuestros colegas de Chile, que han venido desde no tan lejos, desde nuestro país vecino, a escuchar las conferencias y los talleres de esta cátedra de psicoanálisis, y nos alegra mucho porque vemos que este esfuerzo puede llegar no solamente a nuestra comunidad, sino también empezar a integrar a nuestros queridos vecinos del sur, ¿no? Ellos también trabajan en Santiago de Chile, en la Corporación Salvador, con el modelo del DIT, ¿no? Todos tienen experiencia y creo que pueden aportar bastante también con las dudas o preguntas que hayan encontrado en la aplicación del modelo allá. Y también señalar que el equipo chileno que trabaja con el LIT ha hecho la traducción al español del manual de la terapia dinámica interpersonal, que ha estado a cargo del doctor Marcelo Girardi, de Corporación Salvador, y si alguien se interesara en alguno de los ejemplares en español, me avisa para poder señalarles el camino para conseguirlos aquí mismo. Entonces, sin más ni más, welcome, Alessandra, please.
Thank you. Can you all hear me well? Yeah? Well, first of all, thank you very much, Carla, for a wonderful introduction that I understood a little bit of. And I think part of your introduction was to also welcome our colleagues from Chile, which I want to also echo, that you've come all this way for this week, but also particularly to thank them for having translated the book, which is what makes it possible for any approach to start to kind of be known and be experimented with by other colleagues. Without the translation, that is very difficult to do. So thank you very much to you four and your colleagues back in Chile. So the idea of today is that I'm aware, obviously, some of you here are quite experienced with it, some of you have a little bit of knowledge, and some of you probably have no knowledge at all. So we're starting really at quite an introductory level to kind of go over things, which will mean that those of you who are familiar with it might feel a little bit bored. But what I would encourage you to do is to manage the boredom by actually teaching with me, sharing your experience. So when I'm saying things that you've experienced, that you've struggled with, please just let me know. And it doesn't have to be a lecture where I'm speaking for 3 hours. I can do that. I just press this button and I'm off for 3 hours. But it will be much more enjoyable if you actually punctuate what I say with your thoughts and questions and experiences. Okay? The other thing to say is that I think, if I'm not mistaken, that the slides have been translated into Spanish. And have you already said all that in your...
No. But today I'll ask Marisela to send everybody the translation of the presentation to your emails. So don't worry.
Yeah, so just chill, relax, and we'll take care of you for the next 3 hours. Okay, so the first thing to say about DIT is that obviously I want to acknowledge the fact that the development of DIT was a collaboration between myself, Mary Tage, and Peter Fonagy. We are both all very good friends and very long-standing colleagues, and what I'm sharing with you today wouldn't be in existence were it not for their input too. So let me begin at the beginning and tell you a little bit the DIT story, as it were. The first thing that I always say when I'm talking about DIT, which often is not the best place to start when people have either traveled a long way or paid a lot of money to come on the course, is to say that there is absolutely nothing new in DIT. Okay? This is quite an important message to take home. In fact, I think it's fair to say that we spent more time deciding on what we would call it and the acronym, what was it going to be, than actually developing the therapy, because the therapy really draws on the work of many colleagues over many years who have tried to apply psychoanalytic ideas into a brief format. And when we started to think about DIT, in fact, it was only subsequent to work that I undertook as part of a UK-based initiative funded by the UK government, the Department of Health, where they were inviting a group of us to develop competencies for the practice of different kinds of psychotherapies. So it was CBT, it was family therapy, humanistic approaches, and psychodynamic psychotherapy. And the idea was that they wanted us to look at the evidence base and to distill from the evidence base what the core competencies were that underpin good practice in these different psychological therapies. So I was given the task of leading on the psychoanalytic psychotherapy framework. And along with colleagues at UCL, we looked at all the research evidence that there was at the time. We're going back to 2008, so a lot more evidence has come out since. But keep in mind that this was in 2008, when still at that point there wasn't that much psychotherapy outcome research that looked at the effectiveness of psychoanalytic approaches, okay? So we looked at the evidence base where there were studies suggesting that psychoanalytic approaches were effective, but we wanted obviously good quality studies. And once you start to impose a number of methodological criteria, very quickly your vast number of studies reduces to just very, very few. Particularly if one of the things you're looking for, as we were, was that there had to be a written manual that described what the therapists had actually done with their patients. And that immediately cut the numbers back significantly. Thankfully for me, because my job was that I had to then study these manuals and try to abstract the competencies that were implicit in the manuals. You probably won't be able to see this very clearly, but this is the map that we came to. You have to understand that this took 9 months of my life, and I discharged every obsessional tendency that was in my body in order to do this work. I lost friends, family, but at least you can enjoy it today. So we looked at the manual, abstracted the competencies, wrote back to the originators of these different therapies to ask them, does this look like what you had in mind when you wrote the manual? So that was the first kind of evidence to the people who actually developed these therapies. And then we brought together a group of experts in the UK who very significantly had to represent a range of psychoanalytic schools of thought. So we had the Kleinians, the Freudians, the middle group. We even had the Jungians. That's how broad-minded we were. We invited the Jungian colleagues to join us. And we asked them to look at this map that had been developed. And if you go online to the link that is on the slides, if you click on any of these boxes, you get very long drop-down menus that tell you exactly what is involved in the ability, for example, to make a transference interpretation. That's how obsessional this work got. But the beauty of doing this kind of work, and especially when you're fortunate to work with very nice colleagues, is that when we got together with these rather different people who believed in different things at the level of metapsychology, what we discovered is that when you look at what people do in the consulting room, there's much more agreement than you would have if you're discussing the nature of the death instinct or envy, where people can really fight with each other. You know, it gets nasty. Even in psychoanalysis, where we should know better, these things can really kind of mobilize rather aggressive attitudes. But actually, in the context of the discussions we were having about what do you do in the room with patients, there was much more commonality. So what you get here in the map was the result of expert consensus coming from a range of theoretical allegiances within psychoanalysis that everyone agreed this describes what we would hope that a good psychoanalytic psychotherapist would be able to do with their patients. Okay? So this very long diversion is to explain that DIT was born out of this work. So we now had a description of the competencies. The competencies came from work that had been done by other colleagues who developed a range of brief psychoanalytic interventions. And all we did is that we put it in very, we hope, straightforward language that made it then possible for us to develop a manual that described in an accessible way, we hoped, what a psychodynamic therapist working in a brief way would be able to do. And in all honesty, Peter, Mary, and I, when we developed it, it was in large part a strategic decision. We wanted to safeguard psychoanalytic ways of working in publicly health-funded services. We were very clear about this. I don't know what it's like here, but in the UK, there's been a decimation of psychodynamic interventions that are publicly funded. The number of sessions offered is being squeezed every day more and more and more. And one of the problems was that when commissioners who have the money were buying services, they couldn't understand what a psychoanalytic psychotherapist did, you know, because we have a habit within psychoanalysis of speaking in language that makes sense to us if we've been trained in it. But if you say to someone who is the one with the purse strings, it's very important to be able to sustain negative capability. Well, they don't know what on earth we're talking about. So what we wanted to do with DIT was to try and really write it in a way that even a commissioner would be able to understand what we were trying to do, and that therefore when they were comparing and making decisions, shall we fund CBT or shall we fund this, the two ways of working, of course they had different language because they're doing different things, but they were both as accessible as the other in terms of describing what we were hoping to do with our patients. So that was the beginnings of DIT. So when you look at DIT, you hopefully will say, oh, but that looks like Luborsky, or that looks like what Otto Kernberg does in transference-focused psychotherapy. And we will be thrilled if you see those similarities, because those are the manuals that we looked at. So that's what we mean by there is nothing new about it. Now, we were very lucky in the UK that having done this work, when the National Health Service developed IAPT, which is the Improving Access to Psychological Therapies, which was a very big project in the UK, the aim of which was to try to make therapy of any kind more accessible, more quickly accessible to more people who needed it on the NHS, so completely publicly funded. And up until that point, CBT was really, I would say 99% of the time was the approach that was offered. DIT was introduced as something that would provide something a bit different, and of course it's been very hard to provide as much DIT as it is to provide CBT for a number of reasons. The training is longer because in order to do DIT you already have to be psychodynamically trained, and so that's a longer training. There aren't as many therapists, so across the whole of the UK, in London, you get a lot of DIT. If you go up north, at the closer you get to Scotland, there's probably one or two people who kind of can practice DIT, but it starts to kind of really diminish significantly. So we're still struggling, even in the UK, to keep alive psychodynamic approaches in the NHS, but DIT has definitely given us a very helpful entry point. Now, one of the things, if you look at this map, just to go back to it, you'll see there's a little green box at the top. And the green box is quite important because for each one of the maps, whether it's CBT or psychoanalytic, we ask the experts, what would you say is completely distinctive of the approach? So try and say what it is. So for example, the CBT colleague said it's the ability to work collaboratively. That for them was the hallmark of a CBT approach, which is interesting. You see, when you ask the experts what they think is important, they come up with something that might not be intuitively what we think is going to be the answer. So when we asked the same question to our psychoanalytic experts, what they came up with is that they said what's distinctive is the ability to maintain an analytic attitude, and that is the overarching competence in DIT. Now, how we define this, I should say, is that this attitude is characterized by our interest in, and importantly, our receptivity to, the unconscious communications and the way that the transference unfolds over a period of time in our work with our patients. Now, the reason I'm flagging this up before anything else is because as you get to know the DIT model, you will discover that you are asked to do things that when you're trained psychoanalytically, you're told absolutely not to do. Yeah? So it creates a conflict. Yeah? In fact, when we train people in DIT, we find that the best DIT therapists are those who are not psychoanalysts, because psychoanalysts have a lot of unlearning to do. They have to deal with their analytic superego that tells them they mustn't ask questions, they mustn't talk about goals, they mustn't be directive, all of which is very important, and I'm not diminishing the importance of those things. But if you're working in a time-limited way, which is what we're doing in DIT, you can't expect to do what you do if you have 10 years, 5 times a week on the couch. They're not equivalent things. So when we developed it in the UK, we were often accused of destroying psychoanalysis, diluting the gold of psychoanalysis. This was going to be the death of psychoanalytic interventions. And of course, a significant error in those sorts of allegations is that they're not thinking about what we're trying to do. No one is trying to say this is the same as full intensive psychoanalysis. Of course it's not. It can't be. We're not trying to do that. What we're saying is that we're employing a shared theoretical framework of ideas, the idea of the unconscious, of introjection, of projection, all of which we'll come to, and we're applying it to seeing our patients in a very time-limited manner. Consequently, you've got to have a focus. Consequently, that means that certain techniques that are absolutely appropriate when you're doing open-ended, long-term psychoanalytic work are not going to be applicable to a 16-session intervention such as DIT, let alone 6 sessions, where in some services, even 16 sessions in the UK is regarded to be too long. Yeah? Now, how is the speed? Can you follow me? Yeah? Please stop me. Because not only do I speak quickly anyway, but being Italian, I really speak very quickly, okay? So I'm doing my best. This is my best. But I won't be offended if you ask me to reduce even further. Okay. So when you are working briefly, we definitely need to introduce more structure. And of course, the more structure we introduce, it is absolutely right to say that you lose out. You can't have everything. It's a compromise in life. Everything in life has to be a compromise to different degrees. So, of course, if as the therapist you're asking more questions, you are inhibiting free association. Yeah? So you're going to lose out on that, but you might gain in other things. And certainly the qualitative feedback that we've had from our patients who've undergone DIT is that one of the things that they've said is that it was extremely helpful to have a therapist who kept taking them back to a repetitive pattern, to what they wanted to achieve, so that they were really kept focused on where they wanted to be. Very different journey to an open-ended psychoanalysis, where no one talks about cure, no one seems to be interested in whether this is going to make you feel better or not. It's just an interesting journey that we're going to go on. And there's many merits to that. But if you are providing publicly funded services, there's got to be some accountability. You've got to be able to show that your patients are gaining some benefit, however you choose to define that. If we're not prepared to do that, actually, why should we have a place in a publicly health-funded service? You've got to show that it's actually helpful to people. And absolutely we must argue with how we define what is helpful, with what measures we use. They've got to be meaningful to the things that we're targeting. But we can't shy away from actually measurement of our activities. And I know this is a controversial thing to say in psychoanalysis, but I genuinely, absolutely believe that this is essential to do if we want to keep psychoanalysis alive, which is why it's wonderful to see that here you have psychoanalysis in a university context with people who are researching it, as well as having colleagues who just do psychoanalytic work in their private practices. And as long as we keep these dialogues alive, then I think everyone's work will be the better for it. That's my polemical bit. Okay. So let's get stuck into the DIT model a bit. So DIT is, as things stand, a 16-session model. I say as things stand in the sense that the research we've done so far is with the 16-session model, but in practice, a number of services in the UK have had to reduce the number of sessions to 12, and we have also just finished a pilot of a new adaptation of DIT called DIT for Complex Care, which is a 26-session model. I will tell you a bit about that, but maybe at the end. So if I forget, if someone reminds me, I will come back to it. There's no point in talking about that before I've presented the basic model, but that's probably the most up-to-date development, is this 26-session model, which is aimed at patients who have more complex needs, who probably psychiatrically you would say they have comorbid axis 1 and axis 2 disorders. So we're talking really about the personality disordered patients who are also depressed. So we're still always targeting the depression, but taking into account complexity of personality structure. Okay. Now, what we developed it for in the UK, because as I said, it was very much done in the context of these national developments in the provision of psychological therapies in publicly health-funded services, is that we developed it in our minds as a treatment for mood disorders, so both for anxiety and for depression. In the UK, however, we are guided in the National Health Service by the so-called NICE guidelines. I don't know if you've heard of the NICE guidelines, but essentially they come from the government, and they tell you what interventions you can provide for a range of illnesses, both mental and physical. So anything from diabetes through to depression has a guideline, which means that if you are in a publicly health-funded service, you can only offer your patients what this guideline prescribes. And this guideline prescribes as the first course of treatment for depression and anxiety, it's CBT. Psychodynamic interventions are not prescribed for anxiety. They are offered for depression only if the patient requests it, or if they've had CBT and it hasn't worked. Yeah, so it's very, you've really got to kind of, as a patient, you've got to know about the fact that it exists in order to request it. So if you live in certain parts of the country, you've never even heard of it, so you don't request it, so you just get CBT. Or if you are in a place that offers it, then there's got to be very strong grounds for why you wouldn't offer CBT in the first place. And in the original guideline, they said that the therapist, if they were offering DIT, would have to say to the patient that there was very little evidence that it worked, which I thought was a great start for an opening statement to a therapy. I'm here to help you, but actually there's no evidence that actually this is going to work. Now, things are a little bit better than they were 10 years ago when we started out on this journey, but not much better. But I'm saying all this by way of explaining that although we, the developers, develop and understand it as a treatment that is suitable for both anxiety and depression, in practice in the UK, it is only offered for the treatment of depression. Yeah? And of course, this speaks to a perennial problem that the people who make the decisions about these things view the world in very simplistic ways. There is such a thing as a purely depressed patient who has no anxiety at all. And I'm sure all of you who work with patients will say that you probably haven't seen such a patient. They're probably in the Museum of Psychopathology, if they exist, as kind of just depressed patient. But we still have to toe the line, because that's what the government in our country at least is saying to us at the moment. Now, let me tell you a little bit about the acronym Dynamic Interpersonal Therapy, DIT. Why did we call it DIT? So one of the things we wanted to underline was that this was an approach that focused very much on the patient's interpersonal functioning. And of course, what you will say is that, but of course that's what psychoanalysis is about, and indeed that is what psychoanalysis is about. But if you are operating within a more traditional psychoanalytic framework, what we mean by focusing on relationships is that we're talking about internalized relationships, internalized object relationships. And a lot of our classical psychoanalytic interventions relate to those internalized relationships. Now, DIT also formulates in that way, but the focus of its intervention is on the actual relationships in the patient's current life that they are struggling with. So whereas in a classical psychoanalysis we might spend a lot of time making interpretations that relate to versions of your mother, your father in your mind, and we stay there for some time, in DIT, that work is what the therapist does rather rapidly in their own minds in order to translate it into a form that helps the patient to see how these internalized patterns are affecting their relationship with my wife, with my husband, with my best friend, with my mother now. Okay? So by interpersonal, we really meant interpersonal, the relationships we're living with right now. Okay, so that's a little bit different to what classical psychoanalysis does insofar as that's not where it's primarily focused. I think we're all trying to get to the same place, but we get to it in a slightly different way. But the interpersonal focus that we have adopted in DIT is very similar to the interpersonal focus, for example, in IPT, in interpersonal psychotherapy, developed by Klerman and Weissman in the 1970s. Are you familiar with IPT as an intervention, or do I need to say a bit about it? You familiar? Anyone doesn't know about? No, not familiar. Say a bit. Okay. So the story of IPT is really interesting. So IPT was developed as part of one of the largest scale outcome studies in the 1970s in America. It was an NIMH-funded study for the treatment of depression, which was looking at CBT versus imipramine as an intervention for depressed patients. And the people doing the study felt that they needed a control treatment, and they didn't know what to do. So literally, I think on the back of an envelope, they put together what became known as IPT. So they were drawing on their clinical practice primarily as psychodynamically oriented psychiatrists of what they did with depressed patients who came to see them for their regular kind of reviews. And remember that in the 1970s, of course, psychiatry was much more psychodynamically oriented than it is today, and patients actually got quite a lot more out of their psychiatrists than they get today, who are just really prescribing medication and not having consultations with them. So Myrna Weissman and Gerald Klerman, who were the kind of two main psychiatrists involved in this big research trial and were psychodynamically trained, invented IPT, as I say, almost as a kind of last minute, an afterthought. Let's just say this systematizes good clinical practice. You see your patients, you talk to them, you ask them about their relationships, and let's see what comes out of this. And of course, no one expected that IPT, developed in this way, would actually have as much of an impact as CBT. Not only did it have as much of an impact as CBT, but with the more severely depressed patients, it did marginally better. Years and years of written articles debating, arguing, the CBT therapists saying, but our therapists weren't as highly trained as the IPT therapists, and that's why they did better. Because actually they couldn't bear, I think, the fact that another approach, not that it was better than them, it's just, it also helps. Because as we know, about 50% of our patients are not helped by any kind of therapy. So we have to rein in our omnipotence, and those that are helped are probably helped, in truth, because there are a number of shared interventions that we might label them slightly differently, but that actually are conducive to better outcomes in psychological interventions. If Peter were here, I'm sure what he would say is because if you actually have techniques that help a patient to mentalize, it doesn't matter what the technique is, as long as the goal is that you're helping the patient to mentalize, and they will get better. And I think we would be much further ahead in our understanding of how we can help people who are suffering if we abandoned our allegiances to different brands and actually accepted that there are different ways of doing things. They all have something to offer, but we're probably all, in some respects at least, doing something rather similar. I'm not sort of saying everything's the same, but at some core level, there are probably some substantial similarities. Okay? The more interesting research question is, where we do differ, do those differences actually have differential impacts on different kinds of psychopathology? And there I think that, for example, psychoanalytic interventions do have something very particular to offer if you're working with personality disordered patients. Because I think that the intensity and the complexity of the dynamics that are mobilized when you're working with these patients are actually very helped by our understanding of the complexity of transference and countertransference dynamics. Okay? But anyway, that takes us on another sort of line of thought, so I won't go there. So, to go back to DID, it shares this interpersonal focus with IPT. It comes from IPT, and in fact, I would say that my experience of becoming eventually a trainer in IPT was very influential in the development of DID. So you will find in DID what I consider to be some of the helpful bits of IPT. But of course, what IPT doesn't have, it doesn't have a conceptualization of an unconscious mind anywhere within it. So if you wanted to, you could say that DID is IPT with an unconscious. Okay, that might be sort of shortening the story, but that's essentially how I see it. Okay, and I say this with deep respect for IPT because it is extremely helpful as an intervention, and in fact modified my practice even as a psychoanalyst, because of what it made me realize is that in IPT what you do is you get to really know very well your patient's current relationships. And it taught me at the time, when I was just a newly qualified analyst, how I had spent years literally seeing some patients, and I knew less about their actual lives than I knew after 2 sessions of IPT. And that was because I was free to ask questions. And I was legitimized in being interested in what my patients were actually experiencing in the here and now of their day-to-day lives. And being given that license was immensely freeing, and undoubtedly has shaped the sort of analyst I've become, and it undoubtedly influenced the development of DIT. And I think in this respect, Peter Fonagy, Mary Tage and I probably share a number of kind of attitudes towards certain aspects of psychoanalysis, which you probably find reflected in the DIT model. But as I was saying, IPT, wonderful though it is, it didn't actually focus on the activation in the present of these internalized object relationships that are informed by the earliest developmental experiences. And that's something that really was missing, which we have obviously wanted to put back into DIT. So what we're trying to do in DIT is to still formulate absolutely psychoanalytically, to help the patient understand the very delicate interplay between what's going on out there and how what's going on out there is influenced by what's going on in here, and what's going on in here is undoubtedly shaped by the earliest experiences we have of relationships, particularly with significant attachment figures, which get internalized as templates of how I am with other people, and these can become rather entrenched, rather rigid, and keep repeating themselves in terms of influencing our expectations of ourselves and of others in our present relationships too. So in DIT, we put the word dynamic in there to recognize that we remained aligned with a psychodynamic model of the mind. But we are talking here not just of the unconscious in the Freudian sense of the repressed unconscious, because that unconscious requires, for it to make any sense, the operation of autobiographical memory. Repression can't exist unless you can actually remember something and then repress it. But much of the time, what we're working with in any kind of therapy are very, very early experiences of self in interaction with other people that predate the onset of autobiographical memory. So these experiences are stored in what we regard to be procedural memory, which is procedures of how I am with others, what I can expect of others when I'm in pain, for example. That doesn't relate to actual memories that we can recall and discuss in therapy, although I'm sure you will be familiar with patients, and maybe you've done it yourself. I certainly remember sometimes saying, I remember when I was 2 and my mother did this to me. It's highly unlikely that actually I have any autobiographical memory of that. And that doesn't matter in the context of a therapeutic dialogue. These are the narratives we have to tell ourselves and that we can unpack in therapy. But in terms of understanding what we're actually formulating in DIT, much of the time what we're formulating is what we are understanding as procedural memories, procedural templates of relationships that actually continue to exert an impact in the now. Now, the reason that's important is because it helps us to understand that the aim of therapy, or the primary aim of therapy, is not to, dig and go back and understand why we felt the way we feel the way we do, but more to understand that that pattern informs how we approach our current relationships. So indeed, there's less emphasis on the why, the kind of Freud's archaeological metaphor, beautiful though it is, and interesting though it is to speculate as to why I am the way I am. Actually, in order to help people change, if we can formulate the pattern that keeps repeating itself, why the pattern was there in the first place may be less relevant to outcome than we might like to believe. Okay? So what we do indeed is that we reframe the so-called symptoms of depression or anxiety as responses to current interpersonal problems or perceived threats to attachment, so experiences of loss and separation. And of course, a threat to our attachment is invariably experienced as a threat to ourselves. Yeah? And we assume that these perceived threats can both result from and cause difficulties in thinking clearly, not just about what's going on in our world out there that is mentalizing, but also what's going on inside of us, so that we can't read our own mental states accurately, perhaps. Okay? Now, we brought to bear a number of theoretical influences on DIT, and we won't have the time to go into these at all today, but just to flag them up, we're obviously very informed by object relations theory, by Harry Stack-Sullivan's interpersonal psychoanalysis, by mentalization, and by attachment theory. Okay, so there's quite a lot of influences. But in fact, the model, as we describe it in the book, is much more pragmatic. Yeah, so we own up that these are the sort of ideas that are in our minds, but really, in order to kind of do the therapy, we decided to just focus primarily on the how to do it sort of approach. But the commonalities that we share with other analytic approaches are very basic things, and I'm just going to go through them very quickly because they'll be very familiar to you, but just so that we've got a kind of understanding that we're on the same page, even though how we apply these things in actual technical terms is a bit different. So we absolutely acknowledge that our early experiences have an impact on adult functioning. So in order to understand ourselves as adults, we must understand our earliest experiences. We absolutely subscribe to a view that both internal world as much as external world factors inform how we perceive ourselves and how we understand others too. We buy into a notion of an unconscious, as I said, both in the traditional Freudian sense, but primarily in this procedural sense of an unconscious. We definitely formulate and think about what's going on, drawing on key concepts such as introjection and projection. And we also subscribe to a view that the transference is everywhere. And by transference, what we mean here is that we respond to the person of the therapist, but more generally to everyone in our lives, according to developmental models, which can become problematic, of course, because they're not always updated or challenged, because our internal models of relationships are not exact replicas of what has happened in reality. They are inevitably distorted by the operation of defenses, so that what we feel within, no matter how powerful and the conviction with which we may hold certain beliefs about the past, doesn't make them actually true in an objective sense. Now let me take a pause there to see if there's any questions, any observations, particularly from those of you who are also experienced in DIT. Anything so far that I've mentioned that you want me to clarify? Yes.
I was wondering about the analytic attitude that you mentioned that was quite different or challenging in this type of therapy. I myself have conducted deep-based psychotherapy, and I also experienced some difficulties in that specific area. I don't know if you have an alternative attitude to propose more adequate for this type of intervention.
Okay. So what I would say about the analytic attitude, I think it is the hardest bit of DIT. And I would be reluctant to propose an alternative, because I think that the only way we can preserve the fact that DIT is indeed a psychoanalytic therapy is by maintaining the analytic attitude. But I am completely with you that it is the hardest thing to manage, and actually probably even with a lot of experience we can still kind of get lost in it. And the reason being that there are so many aspects of DIT that are much more directive, concrete you could say, that make it hard to keep alive this attitude. And certainly when we listen to the tapes of people training in DIT, it's very, very interesting, because in the first 4 sessions, which are quite clearly delineated, people by and large, unless they struggle with formulation, do quite well. When you get into the middle phase, what you get from a lot of people, not everyone, and these are all very good therapists, I'm not being critical of them as therapists, but more as learning DIT, what you tend to get is a very poor version of CBT. because people don't quite know what they're doing. So they end up doing what they think a CBT therapist does without being trained in CBT, with the occasional kind of bit of psychoanalysis thrown in. And that has been repeatedly our experience of where things go wrong a bit in the model. So for those of you who are not as familiar with the DIT model, the reason that we stress the analytic attitude is that, for example, in the UK at least, we give outcome monitoring forms to monitor the symptoms of anxiety and depression at the beginning of every session, which, as you can imagine, has given heart attacks to psychoanalysts. It's very, very difficult to do this. And what we're trying to say in the UK is that this is done very differently to how a CBT therapist might do it. So although we are, of course, interested in what the scores are, we are more interested in how the patient relates to the filling in of these forms, how it gets woven into the transference relationship. And that's what we mean by the analytic attitude, that in those moments, it would be so easy to get sidelined and to start to be very CBT about it. Oh, I see your depression has got better or worse, rather than actually remain attuned, as we would normally do, to how are they filling it in? How are they looking at me when they're filling it in? What are they putting on there that they're not putting somewhere else? So, for example, I had a patient who had been referred, this was on the NHS, she was bulimic and depressed, but the referral was for depression. And I could see by session 7 or 8 that she was a lot better in all sorts of ways. And yet every week, the scores were 3, 3, 3. I mean, she looked like she was severely depressed, severely anxious. And it became incredibly fundamental to our work to actually unpack what she was doing in filling the questionnaires in this way. Because in her fantasy, these questionnaires were being seen by my manager. And in the transference, I had become completely identified with this mother figure who she felt had let her down. And therefore, to get better meant to let the mother off the hook. So in the transference, she recreated the same dynamic. And once we got to it, we were able to unpack how her fantasy was that my manager would look at her forms and think I was a very poor therapist because she wasn't getting better. So in that sense, staying focused on the analytic attitude, which is more about the function, the psychic function of filling it in that way, rather than approaching it more concretely, is what we mean by the importance of keeping that attitude alive. But I completely agree with you that that is the hardest thing to do in DIT. But we mustn't shortchange ourselves or our patients by trading that in for something else, because I think that's what's so distinctive. Otherwise, the approach will just become CBT, and I think will be less effective with some patients. Anything else?
Therapists, I think that it's true, it's sometimes uncomfortable to apply the instruments with the patient during the, I know, the first 10 minutes of the session. It's true, but it's what you said is true, because it's the time you need every session with the patient to evaluate some aspects of the internalized experience or functioning of the patient. For example, I remember a patient that every session, every time that she flew through the questionnaire, she always wrote some notes in order to read it as a therapist. Not only at the beginning of the session, but at the end of the same session. But at the same time, as a research, it's a good opportunity to have some data that we use at the end of, not only at the end, but throughout the psychotherapeutic process. So it's very uncomfortable sometimes, but I think this is the most challenge we have as therapists when we are training by using this model.
Yes, absolutely. But what's interesting is that when we do questionnaires asking for patient feedback on the experience, do you know, I don't think I've ever once seen a feedback form that the patient complains about the forms they have to fill in. The issue is our issue as therapists. We don't like those forms, but the patients actually, by and large, don't have a massive problem with it. Occasionally, some, I think if you have a patient who relates to the forms as another form of assessment where there's an activation almost of their superego because they feel that, you know, somehow they've got to be the good patient, there I think it can be experienced as quite onerous and difficult. But by and large, it's not the patients who struggle with this, it's us as clinicians. Yes.
I was remembering that one of the titles of applying the model and training in the model is the countertransference that the test or the instrument makes you feel before the patient is going to come in. So you say, how is he going to be? And you start a little bit imagine, and it's a very powerful information developed therapy. Of how you are relating with that patient in particular. And I think that also has to do how you use that instrument to give more potential to your analytic character. Also, it is very interesting how to use a test with the patient and not like interpreting the patient. You know, like when you're before you pass a roach or whatever, you make a theory about the test and for yourself. Not the discussion of how the patient is going and how he feels and how then the session evolves. It's very interesting because it's another tool to show the patient his interpersonal pattern, internal and external. So I think we have been able to use the instrument from an analytic attitude that we were very afraid of. This is so no psychoanalytic.
Yes. Absolutely. I think there's a lot of overcoming of our own internalized analytic superegos, which are not always helpful. We need a superego, but some versions of it are less helpful than others. Now, if you are familiar with the work of Harry Stack-Sullivan, you will probably recognize his influence at the heart of DIT. I don't know how many of you study Harry Stack-Sullivan in psychoanalysis in Chile or in Peru. Is he taught? Briefly, yeah.
As the background of the inter-subjectives or relational.
Okay. Well, this is exactly how it is in England too, and it's a great shame because actually he was a very, very interesting thinker who obviously was writing in the 1930s and 1940s at the time when psychoanalysis was a very drive-oriented model. I mean, obviously, object relational thinking was around, but it wasn't as popular as it is, obviously, these days. So he was an interesting counter-voice to the very intrapsychic model that dominated psychoanalysis at that point. And he was also particularly interested in more cultural, systemic issues. But one of the reasons we have drawn on him a lot is partly because, obviously, IPT too owes some of its sort of developments to his ideas. And I wouldn't recommend you read Sullivan himself because he writes terribly. This is probably one of the reasons why people don't read him. It's actually not a very rewarding experience. But read other people who write about Sullivan, and then you'll have a better experience. But we've taken sort of a number of key things that I just want to draw out because they illustrate also a little bit the model. So one of the things that Sullivan wrote a great deal about was that as human beings, one of the things we're trying to do in all sorts of different ways is to minimize what he called insecurity. So a lot of our behaviors, the way we are with others, even though on the surface they may appear to be pushing people away, we can understand them as ways of actually drawing people near to us, even though it may be in a maladaptive fashion. And he was particularly preoccupied in a way that I think is very helpful given some of the directions that psychoanalytic technique went into. He was particularly preoccupied with maintaining interpersonal security in the context of the therapeutic relationship. So his way of working was that he said the first thing you've got to do is to make this patient feel safe, that they actually want to be in a room with you, that they have a hope that you're going to be able to help them. So this approach, very, very different to what came to be, and I'm going to caricature here a bit, but the sort of classical Kleinian approach where you get a patient from the waiting room, you don't say hello, you don't say who you are, and you go and sit in a room and you say absolutely nothing. So this would have been complete anathema to Sullivan. And indeed, for us in developing the model, we, by and large, I think, understand why some of our colleagues operate in that way, where they give very minimal orientation to the patient. But if you're working in a publicly health-funded service where patients are not acculturated to psychotherapy, so they don't understand why a therapist says nothing to them, the risk is that this is quite a high-risk strategy. Patients may not come back, they may feel too unsettled, not contained enough, and for a brief intervention, we actually thought the most important starting point is to make sure the patient stays in the room. I mean, our goals were not high, we just wanted the patient to be in the room with us. If I may just digress briefly to give you a funny sort of story that sort of speaks to this. I'm sure you will be familiar with the British psychoanalyst Christopher Bollas, very much at the independent school. So he was trained in the UK, but went to live in America and practice in America, and he's still there. And he recounts the story of moving to an office in Manhattan somewhere, and he shared the waiting area with a dentist. And having just been schooled in the British way of doing things, at 2 p.m. it was a new patient. He went out into the waiting area. There was a patient. He just nodded. The patient nodded and went in, sat in his room opposite him, and opened his mouth, at which point Christopher Bollas thought, this man is severely disturbed. And the patient then says, I don't understand why you're not looking into my mouth. At which point Christopher Bollas thought, this patient is perverse. And then there was a knock at the door, and the receptionist, who had by then returned, said, Dr. Bollas, you have the wrong patient. So, at the very least, say hello to your patient, introduce yourselves, ask them who they are, just to make sure you've got the right patient in the room with you. But you know, I'm laughing about it, but at the Tavistock Clinic, where I worked for many years, this was, for some therapists, the standard way of actually operating, to such an extent that we had another very funny experience where this therapist went to collect this little boy. He was, I think, 8 or 9 for his therapy session. And at the Tavistock, in those days at least, if you ever saw a colleague in the corridor, you would always look to the floor. You know, you wouldn't, because you couldn't be seen by a patient to be smiling at a colleague. That, God forbid what that might do to their psyche if you smiled at a colleague. And so the therapist takes the boy into the room, and the boy says to the therapist, have you got real issues with your colleagues? So you can see where I sit on these matters. I would find it very hard to be very po-faced and distant. But of course, in all seriousness, the reason we don't give too much information is because we are trying to get to unconscious material. The only point I'm making is that indeed, if you situate psychoanalytic interventions along a spectrum where at one end you have more supportive interventions as part of the technique, and at the other end you have less structure, less support, DIT is definitely at this end of the spectrum. We do consider it legitimate to be providing supportive interventions within the context of an overall psychoanalytic approach. And that can be contested and argued with. Our reason for doing that is precisely because if you're working in settings where your patients aren't carefully assessed, so that they are quite clearly suitable for a psychoanalytic approach, you have to kind of be a bit more embracing of a range of ways of being that don't easily slot into the perfect ideal psychoanalytic patient who just walks in and starts talking to you and isn't at all perturbed by the fact that you don't say anything. We just can't take that for granted. So that's why we've gone into that way of doing things. And also because I think we feel that this kind of division between so-called supportive interventions and more kosher psychoanalytic interventions doesn't hold up in our minds. We need a range, an extensive repertoire of ways of approaching the patient, because as we know, we can have moments where there are windows of opportunity when our patients can really think with us and make use of a transitive interpretation, and other moments when they can't. And what they respond to much more are containing supportive interventions. So there's a lot more flexibility in DIT, and we build that into the model quite explicitly, not by accident. Okay? The other thing that Sullivan spoke a great deal about, which is very important in the DIT model, is that he advocated what he called the importance of a detailed inquiry. So he would spend several sessions at the beginning of his work with his patients asking a lot of questions about people's relationships. So Mary is an important friend. So how often do you see Mary? What do you feel like when you're with Mary? You know, so these sorts of questions, which we wouldn't normally ask psychoanalytically, we'd be seeing as being sort of doing something completely alien to the psychoanalytic enterprise, are absolutely legitimate within the DIT model. And they're legitimate because we consider that the only way to arrive at a formulation, a psychoanalytic formulation, of a relational pattern that is problematic for the patient comes out of us making this sort of inquiry, understanding why is it that with Mary you feel less depressed than you feel with John, because when you're with John something else seems to happen to you, and we want to really get into the details of those two relationships to see what makes a difference, because that will inform our evolving formulation in our minds that will allow us to arrive at a focus which will then give us the direction for the treatment, okay? And of course, Sullivan, like most of us, I think, believed that the therapeutic relationship was an excellent opportunity to acquire interpersonal learning, and that through what developed between patient and therapist, there were key opportunities to look at problematic patterns. And that's why within the DIT model, we've absolutely retained that focus on what transpires between patient and therapist. But as I'll come on to a bit later, we work with the transference in a much more circumscribed way. So another way of putting this is that in DIT, a lot of the work that is psychoanalytic work is internal work that's done in the therapist's mind, which is then digested and put back to the patient in a way that bypasses the sort of classical psychoanalytic interventions. Yeah? So you're actually digesting a vast amount for the patient, putting it back in a way that makes it very accessible and that they can see is applicable directly to their day-to-day problems. Yeah, so if you think about classical psychoanalysis where the patient comes in with a story from the outside and the direction of travel in our minds is how does that story going on out there help me to understand what's going on in the transference? So it goes from outside to in. In DIT, we go from in to out all the time. We're constantly trying to see how what's emerging here helps us to understand what's going on out there. And again, in the qualitative feedback that we've gained from our patients, that is one of the things that keeps recurring. The patients say it was very helpful that the therapist helped me to see where I kept going wrong in my relationships now. Yeah? So it's all wonderful to make lots of interpretations, and of course when we go to supervision we want to show our supervisors how amazing we are with our interpretations. I've done that too. I continue to do it as I'm still in supervision. But actually with our patients, sometimes what we end up saying to them can seem so mundane, so sort of, really? 10 years of training and this is what I'm saying to my patient? But actually it's the result of so much internal work that only with all those years of training could you have come out with a platitude like that. Okay. Now, I'm just wondering, before we move into the next session, because it's 11:20, do you want to break a little bit earlier? Absolutely. Just before we start, otherwise that will launch me into a new bit.
Mm-hmm. Because we are starting with a more technique part right now.
Yes.
So you want to stop.
Well, maybe take some questions and then have a break.
Okay.
So that then when we come back, we can launch into that part. Any questions or observations before we have a short break? Is everything clear? Well, thank you, Sarah. I mean, that's one of the things that we often hear when we do the DIT training is therapists saying, you know, what you're describing is what we've been trying to do without having a name for it, if particularly you're trying to work in a brief way. And this just legitimizes what intuitively we have been doing. But in terms of your point about technique and what helps, I mean, I've had 3 different psychoanalyses since I was very young. You should have seen me before analysis if you think I'm in trouble now. A lot worse then. And because I had 3 analyses, I had the opportunity, and I made an explicit decision to try different kinds of psychoanalysis. So I had my contemporary Freudian, I had 2 contemporary Freudian analyses, I had a Kleinian analysis, I had independent supervisors. And at the end of the day, they were all extremely good. And they all actually were quite similar. I'm sure, as I said at the beginning, if they got into a case discussion about theory, they would have argued for hours about certain things. But in fact, because they were so skilled, what they were doing was in fact very similar, even though the brand name was a bit different. And for me, that was probably the most important experience of my entire analytic training over many years, is to have that reassurance, because I felt it firsthand, having gone to some of the big names who represented the contemporary Freudians and the Kleinians, and actually, they were very, very similar. And very good, and I'm deeply grateful to them. Okay. Any other questions, or shall we have a quick break?
Alexandra,
Yeah.
I was wondering when you were talking before about the procedural memory, that like, this information that is so important, not so much the why, but how patients like communicate. You know. I was wondering, what is your opinion about using the nonverbal procedural communication of patients? Because I feel that you have to be like really like into it. If you manage to make a safe space for them, then I think that it's like your role, the possibility of us as therapists to show patients how they communicate, even in that level, could be like priceless, like something that other people, our friends, don't do with us. And if it's a safe space, do you think that it could be helpful, and if it is safe for patients, that you mirror those kinds of communication and the predictions that may be there?
Yes.
Is it safe?
Yes.
Can you do it?
Yes, absolutely, 100%. And we should have put that in the manual, but we didn't at the time. But in fact, if we have time, the case I'm going to be describing, one of my cases, absolutely is a good example of how what really shifted the work was me making use of my somatic countertransference with this patient, actually. So hopefully I'll come back to that in the clinical vignette, but absolutely, yes.
Okay, I think we should stop for 10 minutes, is that right? Okay, 10 minutes, and then we'll resume here. So it's 11:25, 11:35.